Before that, I just want to mention two things. They are already given. Most of this topic is given in Vasudevan very well. So you need not go anywhere outside to read this. And there is one more thing which is given in your textbook is about mutagens and anti-mutagens. It's pretty clear, so I would want you to read it from there. All right. So you can read up mutagens and anti-mutagens with examples. So that will be your question in your assignments. Only thing you have to remember is mutagen. Muta is something which is mutation, right? Muta can be mutation. Gen is something which has the capability to generate a mutation. So mutagens are those substances which have the capability to cause a mutation in the DNA of a cell. And if you remember, we studied a little bit about chemical carcinogenesis in the last class. There I told you the basic molecular mechanism happening in chemical carcinogenesis is firstly initiation followed by promotion. So initiation is when the mutation happens. So mutagens are also, they can also be called as the initiators of chemical carcinogenesis, right? And promoters are those which stabilize the mutation and promote cell division. So mutagens are basically those chemicals which are capable of causing a mutation, and that mutation might be then stabilized and it might get passed on to the daughter cell, causing a malignant proliferation. So read up mutagenesis and anti-mutagens from the textbook. And in addition to the class, I am assuming all of you are going to go through the textbooks. For most of my lectures, I do not include what is given in Vasudevan because it is a given that you will be studying that textbook, right? So with that, let's move on to today's topic. Today's topic is mostly from Vasudevan. There's not much difference from what is there in the slides, from what is to what is there in the text. I've included the same tables. What we have to understand about tumor markers and cancer therapy is the principles based on which we decided to use them in the management of cancer. So we have something called as tumor markers and principles of cancer therapy, right? So when a cell becomes, right, when a malignant proliferation is happening, there is also a change in the expression of genes, right? DNA is mutated, right? And a lot of genes get activated, right? So what happens is there is also a change in the set of genes that are getting expressed. We know that some genes will be silenced, like the genes which promote apoptosis or the genes which are tumor suppressor in function. Those genes are typically seen to be deleted or damaged in case of tumors. And proto-oncogenes or the growth promoting genes are mainly the type of genes which get upregulated in cancer cells. Along with that, sometimes there might be some other genes which might start expressing, or which might start getting expressed in these cancer cells, and they secrete certain products which you can identify either on the surface of the cells or in the body fluids, serum, to be more specific. So these molecules are called as tumor markers, which means that their appearance in the serum is indicative of a tumor. So there are a good number of molecules which appear in the serum in case of cancer patients. There are certain cell surface markers which appear on the surface of the cells, uh, and they can be detected in tumors. So there are many of those. But before we select a marker, a molecule as a tumor marker, there are some criteria that the tumor marker should fulfill. So if you look at the slide firstly describes what is a tumor marker. It's a biochemical substance or a set of substances which can be detected in the serum which indicate the presence of a tumor. These biochemical markers are produced from the tumor cells. And what can be these various markers? They can be enzymes, they can be hormones, they can be proteins, they can be antigens. So there is various different category of tumor markers which are now being identified, and a good number of them are used for cancer management. Now, when we select a particular tumor, when we select a particular molecule to, be used as a tumor marker, there are certain specific criteria that the tumor marker should fulfill. This is important. If some of you go later into research and you are doing research on cancers, then and if you are trying to look for a marker or a molecule which can identify a particular type of cancer or help in staging of a cancer, these are some of the considerations that you'll have to keep in mind before selecting a particular molecule as a tumor marker. The first point says that it should be specific for malignant transformation, which means that this tumor marker should appear in the serum, or it should increase in the serum only when there is a cancer developing in the body. And in the absence of any cancer, its levels should be either less below a certain cutoff range, or it should not be there at all in the serum. So essentially it should be specific to a cancer process. Second point it says is it should be specific for the malignant tissue, which means again that it should come out from a particular type of cancer cell only, so that the moment you detect this type of molecule in the serum, it should direct you towards the presence of a certain type of cancer. So presence and elevation of this molecule should give you an idea about the cancer and a very, very specific type of cancer. Third thing it says is it should correlate with the tumor mass and help to determine the prognosis. What does that mean? It means that as the cells of the tumor keep increasing in number, the level of this marker should also go up in the serum. And if you employ some therapy and you are reducing the tumor cells, or you're removing the mass, or you are destroying the cells by means of treatment, and the number of cells come down, when they come down, even the level of this tumor marker should be coming down in your serum. So just by looking at the value of that particular marker, I should be able to tell, oh, now my tumor is shrinking in size, or oh, my tumor is still growing. It should give you an idea about the growth or destruction of tumor cells. Fourth point is it should ideally help in staging of the tumor and in assessing the extent of its spread. If possible, if we are able to get the marker whose levels can tell us how much a tumor has spread to the surrounding tissue and to distant tissues, that would be amazing. Fifth point is it should help in monitoring the treatment. Like I said earlier also, when you give the treatment and the tumor cells are destroyed, concomitantly even your tumor marker levels should come down, so that by looking at the tumor marker, you should be able to tell, yes, that my treatment is working, the cells are getting destroyed. Should help in follow-up or detection of recurrence. Suppose you treated a patient, the patient went into remission, right? Then you have to keep following up that patient and checking whether the tumor has not come back, right? So if you are able to get a marker which you can test in the serum, which can tell you that the tumor is coming back. For example, there was a particular molecule that you tested in the serum, it appeared in the serum and it started increasing, which gave you an indication that the tumor is growing inside. So you started the patient on management, appropriate drugs, appropriate surgical measures, then the tumor started regressing. You could detect it because your tumor marker levels were coming down, and then the tumor marker levels were again below the cutoff range where it becomes a significant value. So they were negligible or very, very less in serum. And then when you call the patient for a follow-up after say 2 months or 4 months or 6 months, reappearance of that tumor marker should correlate with reappearance of the tumor. So The molecule should behave in such a way that it keeps telling you about the behavior of the tumor. So those are the characteristics that an ideal tumor marker should have. But in practice, we rarely find any molecule which follows all these criteria. Some molecules follow some criteria, some molecules don't follow some criteria. In the sense, some molecules are very, they correlate very well with tumor load, and they can tell you about the recurrence of the tumor, but they are not specific, which means that they might be elevated in some non-cancerous conditions also, right? Or there might be some markers which get elevated when the tumor is present, but they are not reduced once the tumor load is brought down. So different molecules give you different challenges, right? So this is the present scenario. This is the current situation where still we have not found the perfect tumor marker, but still good number of markers are used in cancer management because they will tell you specifically about one or more type, one or more patterns of the tumor. All right. Yeah. So these are the drawbacks. They do not fulfill all the criteria, and they are mainly employed to monitor the prognosis or response to treatment and detect recurrence. So what is not there is tumor markers alone cannot be used to diagnose a tumor. You cannot do one blood test and tell that a patient has cancer, right? So there's a whole gamut of tests that you'll have to run. You can, including imaging, specifically imaging, might require some hematological tests if it's a blood cancer. So multiple diagnostic procedures are used to identify a cancer. But when you put the patient on treatment and you want to see whether your treatment is working or not, or whether the patient is responding to the treatment, or if the tumor is coming back, those are the main areas where we employ the use of tumor markers. Again, I have told you, imaging, morphological examination of the tissue, which is your pathology and histopathology, with imaging, where you use radiological techniques, those are more useful to arrive at a diagnosis. Histopathology is very, very specific, combined with immunohistochemistry. In immunohistochemistry, you basically look for markers on the cell surface, right? You treat the tissues with antibodies for a certain type of marker, and if the particular marker is present on the tumor cells, the antibodies will bind to those marker on the tumor cells. Those markers can be present on the membrane, they can be present in the cytoplasm or in the nucleus, and appropriately those markers are going to get stained if they combine with the antibody, and you can see all this under the microscope. That technique is called as immunohistochemistry. Immunohistochemistry basically detects markers in the tissue. Tumor markers which we use in biochemistry detect molecules which are present in serum or body fluids, serum mostly. So this is a table from your textbook where it gives you what are the various types of tumor markers and where do we estimate them, in what type of cancers do we estimate them. So this is something you'll have to memorize. What we will do is we will see, or we will go over some important tumor markers, right? Tumor markers can be further divided into oncofetal antigens, proteins, enzymes, and hormones. Excuse me. Yeah. So alpha fetoprotein is an oncofetal antigen. What does an oncofetal antigen mean? Alpha fetoprotein is a protein which is usually expressed in fetuses, right? In intrauterine life. And it is not usually seen in growing people or in adults. But in certain cancers, the genes which express this protein get activated, and this particular oncofetal antigen reappears in the serum, right? So it is a glycoprotein of molecular weight around 70K, and it is secreted in the or synthesized in the fetal yolk sac. In adults, the normal range is less than 15 nanograms per ml, right? But There are certain cancers like liver cancer, teratocarcinoma of the ovary, and germ cell tumors where these antigens start getting expressed again. There's one more condition, which is a non-cancerous conditions where AFP levels are detected in the maternal serum. That is in mothers which carry a baby which has a neural tube defect. I think in your embryology, they must have taught you about neural tube defects. So you have a gamut of diseases, a lot of diseases which happen when there is a defect in the formation or the development of the neural tube and related structures. You have anencephalines, and even for Down syndrome, you check for AFP levels, right? So again, this is not a marker which only appears in cancers. It can appear in pregnancy also. Second marker is, which is also an oncofetal antigen, is carcinoembryonic antigen CEA. CEA you will see in colorectal cancers and pancreatic cancers, ovarian cancers, as well as gastric cancers. So it is not specific for the organ of cancer, but again, it is more of a prognostic marker. It is also elevated in non-cancerous conditions like IBD, pancreatitis, and in heavy smokers. So you need other diagnostic modalities to confirm your diagnosis of cancer if you detect a CEA. So no doctor will detect or identify or diagnose a tumor based on a tumor marker. It will be based on the clinical history, family history. If there is somebody else in the family who is suffering from a cancer, and it will be supported by radiological examination, all your imaging techniques, and your morphology or your histopathology. And then they do a carcinoembryonic antigen to see the severity of the disease. Next is PSA. It is normally secreted by the epithelium of the prostate gland, and normal value is less than 4 nanograms per deciliter. It is elevated in cancers of the prostate, which is in cancer, prostate cancer, it is usually more than you can say more than 40 nanogram per deciliter, or definitely more than 10 nanograms per deciliter. But any value between 4 to 10 nanogram per deciliter is very, very non-conclusive. And there is another disease of the prostate which is seen in older men. As the age progresses, there is a slight enlargement of the prostate gland, right? Because the glandular cells proliferate in the prostate. It's a non-cancerous disease, but even in that condition, the PSA is elevated. Hence, again, histopathology and cell morphology from the prostate gland, that specimen, proper examination of that specimen becomes important to identify prostate cancer. And once you identify cancerous cells in your slide, then you can do a PSA level to check the prognosis or response to treatment in case of prostate cancer. CA125 is specific for ovarian cancers. It's a protein, it's a glycoprotein. It's a good marker. The levels of CA125 go along very well with the size of the tumor and the extent of the spread of the tumor. And also, if the tumor recurs, that can be identified by another spike in CA125 levels. So, CA125 is a good marker. Beta HCG, it is a glycoprotein secreted by the syncytial trophoblasts. And this molecule has two subunits, alpha and beta. Alpha subunit is a protein chain which is similar to the alpha chain of other hormones like FSH and TSH. It is the beta chain of HCG which is specific to your syncytial trophoblasts. Right? Normal levels are less than 20 international units per liter. Beta HCG levels, beta HCG levels are mostly employed to prognosticate choriocarcinoma. That is, it's a gestational trophoblastic tumor. To monitor the behavior of choriocarcinoma, that is the most common setting in which we estimate beta HCG levels. But Beta HCG is also elevated in other tumors like germ cell tumor, testicular cancer, and something called as a hydatidiform mole. Right? 1 second. Yeah. Beta HCG levels increase to thousands and to lakhs in case of choriocarcinoma, right? You don't see such a severe elevation in other tumors. The elevation is massive in choriocarcinoma. So, it is very, very beta HCG elevated to this level, highly indicative of choriocarcinoma. Right. So these are some of the important tumor markers that you should know about. Other than that, there are other tumor markers which are indicative of specific tumors. I told you there are some of hormones are there. So calcitonin is a marker which is a tumor marker for medullary thyroid carcinoma. Similarly, you have neuron specific enolase which we identify in neuroendocrine tumors. Then you have acid phosphatase again, which you can which gets elevated in prostate cancer. And alkaline phosphatases are usually alkaline phosphatase. It's present in a very high amount in the bone. So whenever a bone is affected by cancer, or there is some other cancer which spreads to the bone, which we call as metastasis, in that condition, elevated ALP levels indicate involvement of bone, right? Then immunoglobulins and Bence-Jones proteins are some of the markers of liquid cancers, multiple myelomas, etc. Right? You have VMA, vanillyl mandelic acid. It comes in tyrosine and phenylalanine metabolism. When VMA levels are increased in the urine, you can identify these tumors, pheochromocytoma and neuroblastoma. So these are some of the examples of various tumor markers and the conditions in which, or the cancers in which these are specifically elevated. Yeah. Last topic is anti-cancer therapy or principles of or biochemical basis of the drugs that we give in cancers. Different cancers respond to different types of anti-cancer therapy. Anti-cancer therapy is not my topic. I am only going to deal with the chemotherapy where we are talking about drugs. But what you have to understand is different cancers respond to different kinds of therapy, right? There are certain, so cancers can be either solid cancers or liquid cancers. Liquid cancers are all your blood cancers, right? Whatever is present in your blood. Solid cancers are your masses or your tumors. Typically, solid cancers will respond more to your surgical management, where you can excise the tumor, remove the cancerous mass. But there are some cancers which are called as radiosensitive cancers. They respond very well to radiotherapy, and the way they say is that the cancer just melts when you start the patient on radiotherapy. Whereas liquid cancers, there is no surgical management there. Liquid cancers, again, will be treated mostly by your radiotherapy and your chemotherapy. So, chemotherapy is always there. It's called as adjuvant therapy, but you might have to do some debulking procedures where you remove the tumor load. So you remove the main tumor and then you start the patient on chemotherapy, or you do concomitantly you do radiotherapy and chemotherapy. Every modality, whether you do, how you employ these different modalities of treatment depends on the type of the tumor, and it also depends on the stage of the tumor. If the tumor is progressed to a very, very late stage, so usually tumors will be categorized into 4 stages: stage 1, 2, 3, and 4. And stage 4 usually tells you that the tumor has metastasized. Metastasis means it has gone to the tissues beyond its tissue of origin. For example, if it's a breast cancer and it has gone to your it has gone off to blood, or it has gone and affected the spine, or it has gone to the lungs. Excuse me, that is a metastatic tumor, right? And stage 1 and 2 mainly are related to, in stage 1 and 2, the tumor has not gone beyond the boundaries of the organs. This is a very, very broad outline of staging, but if you have a brief idea, you may be able to just understand things better. Stage 1 and 2 is usually within the organ of origin. It has not gone out. And 1 and 2, the main difference will be in the size of the tumor or the cell, uh, number of cells which are tumor, basically the size of the tumor. Stage 3 usually indicates local spread. For example, if it's an ovarian cancer, if it spreads to the pelvic wall, that indicates stage 3. Usually it's a local spread. And stage 4 is distant spread. And usually surgical intervention is employed for stage 1 and 2, sometimes for stage 3 also. But once there is a local spread, you cannot remove all the structures which are around the original tumor. Then those cancers are sometimes not treated by surgical means, but you employ mostly radiotherapy or chemotherapy for such tumors, mainly for stage 3 and stage 4. Right? This is just a very broad, crude outline of the way cancer is managed. Let us come back to our topic, which is chemotherapy. The drugs which are used for chemotherapy obviously are going to cells which are going to prevent cell division and cell proliferation and halt the spread of tumor cells, and if possible kill those tumor cells. So those drugs are hence called as cytotoxic drugs. The good thing about these cells is that they mainly attack the steps of DNA synthesis or the steps of cell division. So they usually affect the rapidly dividing cells, and they do not affect the cells which are not in active cell division. So you can say that the cells which are in G0 phase are not going to be so much affected compared to cells which are in your S phase, which are synthesizing DNA, or M phase, mitotic phase. Cytotoxic drugs, hence, are more effective in killing rapidly dividing cells. So hence they are more effective on tumor cells and they do not affect the normal tissue cells. Please mute yourself. Somebody's mic is on. Yeah. So we understood that they kill rapidly dividing cells. But at the same time, what you have to understand is there are some normal cells in our body which are also dividing on a very frequent basis. And these are usually the lining cells of the epithelium. It can be respiratory epithelium, but it is more like GI epithelium, then blood cells, WBCs, RBCs. Again, turnover is quite rapid. Skin cells and hair cells. These are also rapidly dividing cells. And when you give a person chemotherapy, you are typically going to see features like nausea and vomiting, which happens because of the damage to the cells of the gastrointestinal system, because they line the GI system and they get damaged. So it causes a lot of nausea and vomiting in those patients. They can go in for cytopenias, like the blood cell number can reduce. They can have low WBC count, low RBC count, low platelets. Then there is a lot of hair loss in cancer chemotherapy, because again it affects the rapidly dividing hair cells, and the patient can also have rashes or something called as dermatitis, where the radiation is going to affect the skin. So these are some of the side effects that can be seen with chemotherapy, because chemotherapy or the cytotoxic drugs in general affect all the rapidly dividing cells. Second thing you have to remember is that cytotoxic drugs are always going to kill a proportion of the total number of cells and not the actual number, right? So if, say, there is a tumor which contains 1,000 cells and the capability of the cytotoxic drug is, say, 5%, So if the number of tumor cells is 1000, it is going to kill 50 cells, right? If the tumor cell count comes down to 100, it's going to kill 5 cells. So as the tumor load reduces, the number of cells killed by the cytotoxic drugs also come down, because it always hits a constant proportion of cells, and that will be probably the proportion of cells which are actively dividing at the time of giving the treatment. That's why we give treatment in cycles, right? Those cycles are determined by how rapidly the cells are expected to divide. Also, that is one of the criteria for giving a cycle pattern. When you give chemotherapy, you give it in cycles, right? So that has to do something with cell division also. Which means that if a constant proportion of cells is being killed by the cytotoxic drug, it is very unlikely that the cytotoxic drug is going to finish the tumor completely or kill every single tumor cell. So what you have to understand is we bring down the number of tumor cells to a certain minimum number, so that our immune system can then take care of those cells by themselves, right? But there's a catch there, because cytotoxic drugs also affect your immune cells. Yeah, so again, there's an exhaustive table in your textbooks. This is the same table. So uh, this text, this table basically gives you the name of the drug and the class to which it belongs to, right? And the modality of action of each drug. I had individually made a slide, but then I realized this table was there in the textbook. So this is good enough. So it is a receptive inhibitor of dihydrofolate reductase. It resembles folic acid and nucleotide synthesis, which is essential for synthesis of DNA. So it inhibits synthesis of DNA by inhibiting nucleotide synthesis. 6-mercaptopurine is a purine analog, prevents amination of IMP to AMP. If you read your textbooks, it is given in your textbooks that what are the type of cancers in which these drugs are employed in. What I'm basically telling you is, I'll give you that question in the assignment of tumor markers. The category of drug, drug which it belongs to, mode of action that, right, in what tumors this particular drug is used in. So that is right. So yeah. Along with these specific drugs, there is something called as monoclonal antibodies, and mechanism of action of monoclonal antibodies is that they are antibodies, so they are going to go and bind to something, and binding of the antibody to a particular molecule in the cancer cell is going to prevent the process of evolution of that cancer. For example, if there is a way that it makes a cell susceptible to one way in which a monoclonal antibody can act. A monoclonal antibody can block the or go and bind to the growth factor receptors and prevent the action of the growth promoter or the growth factor in causing more cellular proliferation. The antibody can block the growth factor itself and prevent the growth factor from binding to the growth factor receptor and causing actually binds to the vascular endothelial growth factor. Vascular endothelial growth factor is important in development of blood vessels around the tumor. So this basically starves the tumor by not letting the blood vessels to appear around the tumor. If there's no blood vessels, there are no metabolites and nutrients reaching to the tumor, so the tumor cells are going to get disturbed. Then there is an antibody called as trastuzumab, which acts on the HER2 receptors of breast cancer. Here, there is something you have to remember, that uh, certain cancer, like I told you, how tumor markers appear in the serum, there are certain molecules which, if they are present in the tumor, can tell you about a certain way in which a tumor will behave. For example, in tumors of breast, there is something called as ERPR, that is estrogen receptor and progesterone receptor. These receptors are nuclear receptors, and presence of these receptors, especially the ER or the estrogen receptor, gives you uh, an indication that if you give a particular drug, that drug can bind to this receptor and help in destruction of that particular cell. An example is the drug tamoxifen. If you take the breast tissue, which is a cancerous tissue, you do a ER testing by immunohistochemistry. You have to check for this marker in the cell. If this tumor is positive for estrogen receptor, then you can give tamoxifen to the patient, because tamoxifen is a drug which will bind to the estrogen receptor and help in destruction of the that particular cancer cell. So you have ERPR and HER2/neu, which are important markers that you do in tissues to check if the cells are going to respond to a particular type of treatment. Yeah. So these are the other examples of various monoclonal antibodies that can be employed in treating cancer. So this completes the topic of biochemistry of cancer. If you have any doubts, you can ask now.